This is PopHealth Week on Healthcare Now Radio. I'm Gregg Masters, your co-host and executive producer. Joining me in our virtual studio is co-founder and principal co-host Fred Goldstein. Fred also wears the hat of president at Accountable Health, LLC. PopHealth Week is your go-to platform for peer-to-peer conversation with industry leaders, innovators, and ecosystem stakeholders, including payers, providers, patients, vendors, and the regulatory communities. We come together to swap the best ideas and strategies in population health. Connect with us via www.popupstudio.productions or drop me a direct message on Twitter via @GreggMastersMPH, and that's Gregg with 2 Gs. You can reach Fred direct via Twitter at FSGoldstein or www.accountablehealthllc.com. Today, we're in the company of Justin Monger, CEO of MedSure Systems, a medication management service that enables better patient outcomes, improved practice operations, and reduces total spend. MedSure Systems is a developer of a medication technology intended for patients and physicians. The platform links the pharmacy, the physician, and the patient and can maintain medication management and improve health outcomes. Fred, the mic is yours.
Thanks so much, Gregg and Justin. Welcome to PopHealth Week.
Thanks for having me here, Fred. Looking forward to the discussion.
It's a pleasure to get you on. Why don't we start? Give our audience a little sense of your background.
Sure. I spent 35 years in aerospace and defense developing very large complex systems for the U.S. military. I retired kind of early, got out, and I figured out what I wanted to do. Took some looking around, and I kind of made an orthogonal move over into healthcare, a very different area. And what drove me to that is really the heart of my passion for this whole thing. We had a large family, 6 kids, and one of my sisters suffered from addiction issues her entire adult life. I think we all know somebody like that, whether it's alcohol or prescription drugs or whatever the case may be. We all probably know somebody that's been in that boat. And I looked at that problem and I said, you know what? This doesn't take the next iPhone invention to fix, or at least make a huge dent in the problem. And so we came up with this concept that's now MedSure Systems, pursued it, and we're in a place to deploy it. And what's really been the most rewarding thing is that everybody on this team understands the chance and the opportunity that we have to really move the healthcare needle in this country and make a huge dent in this problem of med adherence, prescription drug abuse, and the rest of that. And so it's a day-to-day thought for every one of us, and it's what makes us want to get up and get out of bed and get to work each day.
So what is the MedSure system?
Well, it is a med management service. It's now Medicare reimbursable, and it is a complete network that connects the patient, it connects the doctor, it connects the pharmacy, and it connects the caregiver. And the caregiver could be a family member or it could be a paid caregiver. And then it connects a personal MedSure coordinator for the relational care aspect of this, all together so that they can monitor and ensure that the patient stays on their medicine regimen.
I've looked it up a bit on the website and read through your materials, etc. You've got this box that goes out with the medicines in prepackaged delivery system on a long set of them, I guess, a strip that is then coded for each day in the meds. And so is that your company providing the meds and doing the pharmacy back-end services, or is it just providing that piece of it and then the coach?
We have a couple of partner pharmacies. And so when a patient comes into the program, all the prescriptions are transferred to our partner pharmacy. We have one on the East Coast and one on the West Coast. And the partner pharmacies put together the strip packs, just like you see here, that lists the drug, the day, the name of the patient, when they're supposed to take the meds. And so the first pack might have every pill in it that you take at 8 a.m. The second pack might have every pill you take at noon. And the third pack could have everything you take in the evening. And it also includes over-the-counter drugs and nutraceuticals, supplementals, vitamins, all the rest of that. So our partner pharmacy puts that together, ships it to the patient. We ship a device to the patient that actually cuts off the strip pack, dispenses it. We ship that to the patient if they want to use that. Some patients prefer just an app. Some patients want the app and the device. They're completely interchangeable.
And so it automatically feeds out that particular pack for that time of day for that individual. And then I noticed there was an alert on the app if they have that, correct?
Exactly. So let's say it's 8 o'clock in the morning. It's time to take the meds. The app will send a notification, it'll beep, it'll send them a text telling them it's time to take the meds. They come over, and if they've got just the box, they tear off the pack, it's perforated, and take the meds. In the case of the device, it'll beep, it'll flash, it'll text, it'll call them, whatever we set it up to do. The patient comes over, hits the dispense button, it cuts it off, spits it out. And then either the app or the machine, they both ask the patient, did you take the meds? They hit the I took it button, everything goes by cellular up to the cloud, everybody's happy, everything's recorded. And then the key part here, and Fred, this is something that's unique, is we have a relational care, a human side of this component, what's called a human intervention, not just a digital intervention. All the electronics there, that's the digital intervention. If the patients say they're an hour late taking their meds, our personal MedSure coordinator goes through a protocol where the first step might be you text the patient. That doesn't work, you call the patient. That doesn't work, then you text the caregiver. If that doesn't work, you call the caregiver. We just wrapped up an 11-month evaluation with a large practice here in North Dallas, and we never had to go above calling the caregiver in order to get the patient back on their regimen.
And do you have a sense, I mean, that brings up some interesting analytics. Do you have a sense of how many of those prescriptions or what percentage result in you having to do some sort of outreach with a text or a call?
That's a great question. I think the important thing to note is that without any intervention, digital, human, or otherwise, about 50% of the meds are not taken on time. So the med adherence rate just as a whole in this country is extremely poor. 50% of the time, people literally don't take their meds. Through our 11-month evaluation, we got that up to 99% for all the patients in the evaluation. Now, the number of times, the statistics I don't have off the top of my head, but we certainly could pull those up. How many times did we have to remind the patient through the personal MedSure coordinator? I would have to look that up to get that number. I don't have that one off the top of my head.
Got it. Yeah, that would be a fascinating thing to look at when I think about it. Obviously, you've got the adherence level associated with nothing. You have the adherence level associated with your device and potentially an app and the reminder capabilities within that. And then obviously you have that third level to kick it up, potentially, I would assume, even higher. And as you said, you get to that 99% level. And how large study was that with, or number of patients?
The evaluation we did was with this particular practice told us, Justin, I want you to do a handful of patients, a little less than 10, and let's run it for 11 months. As you know, doctors are pretty conservative. They said, let's see how it is at the end of 11 months. Does it really work? Is Medicare really going to pay for it? Because you never know until you do it. Is Medicare Advantage going to pay for it? And so we ran that 11 months, got the 99% number. Medicare paid for it in full. Medicare Advantage paid for it in full. And so now this doctor has opened it up to the balance of her 18,000 active patients that she has. Mm-hmm. And we're in the process now of rolling that out.
That's fantastic, Justin. And in terms of your call, the staff that's accepting the calls, is there a certain training or background that they have for that position?
Yes, all of our that's a great question. All of our personal MedSure coordinators were at some point in time active in the healthcare, usually as a certified medical assistant. Could have been a phlebotomist, an X-ray technician, back office operations, front office receptionist. They're definitely involved somewhere in healthcare. And then we found the ones that really have the empathetic approach. Because if you're going to build relational care in order to change behavior, because that's really what we're trying to do here, is change behavior, get people to take their meds when they're supposed to, it really takes a bit of coaching, a bit of partnering, and a bit of empathetic listening to the patient in order to get them up to that 99% level.
Mm-hmm. So I think, Justin, I may have seen this on the website or not. Is it sort of like a primary staff model that individual is assigned a specific group of patients? So I, Fred, know when I call in, I always have the same person? Or is it just whoever might be in at that time that reaches out to me?
You will always get the personal MedSure coordinator that you were assigned to, or their alternate, because we cover 7 days a week.
Correct.
Okay. Yeah. So you'll get one of two by name, unless it's way after hours. And then there will always be a human being that answers the phone, takes a message, and the personal MedSure coordinator, your particular one, can get back to you during regular business hours.
Yeah, that's fantastic. I think that primary model of associating, to be able to say, as you talked about, establishing that relationship is critical to get that trust to push that adherence rate up.
Yes, absolutely. And one other thing, if I could add, Fred,
sure.
In terms of the adherence rate, I mentioned that the number in this country is 50%. And frankly, you know what? It's not a whole lot different in other countries of the world. This is not a problem that's unique to North America by any stretch. And on top of that, the impact of those that 50% med adherence number is on the order of $300 billion a year in completely avoidable hospitalization and recovery costs. That is a massive number by any stretch. And there are some companies out there that claim it's 600 billion. 300 billion, 600 billion, it's a major number. Then you put on top of that the human cost, 200,000 premature deaths every single year just from those that have hypertension, okay, high blood pressure, and don't take their meds. Then you put on top of that the uncounted number of people that have an incident, they don't die, okay, but they spend the next 2 years of their life in a nursing home staring out a window, okay? Then the third factor on top of that, and this is the one a lot of people don't know about, is $25 billion a year is assessed with hospital groups and physician groups and individual physicians. If a patient comes out of the hospital and they are readmitted within 30 days and they haven't taken, and they're readmitted because they haven't taken their meds, there are $25 billion a year in penalties to those groups because of that. And 47% of the doctors in this country have been touched by that penalty.
And that raised an interesting point. Have you sought to take this to market as one of the 30-day readmit programs and push it into that?
We are absolutely in discussions to do that, particularly on the value-based care side. There's two basic business models. There's the Medicare reimbursable fee for service. You provide the service, you get paid. Okay, so there's no rewards or penalties there. On the value-based side, if you can keep people healthier longer and keep them out of the emergency room, then there's lots and lots of money to be saved. So on the value-based side, that's exactly the discussions that we're having at this time. Our current patient set for the two practices we have signed up are both Medicare fee for service. But I expect within the next month or two, we'll have a value-based care model in place.
And, getting back to those three levels you talked about of outcomes, et cetera, and better results, I'd really add a fourth one. We did a program for persons with schizophrenia years ago, back in the day for Medicaid, and took adherence rates from a 23-day average fill rate per month to 29 using a community-based model. We didn't have the technology that we have today, which is really fascinating. And obviously we saw substantial drops in ER visits, 54%, and hospitalizations, but just quality of life for the individuals, being able to taking those medications and being able to get back some level of a higher quality is just critically important to these adherence. I mean, some things like hypertension, you may not feel it, but there are others where clearly there's a major impact in that for an individual. So,
well,
really,
Fred, you've touched upon a really key point there. And it's, everybody talks about, you take your meds, you get a better patient outcome, right? You feel better, you get a better quality of life. But the direct impact of that, okay, that's not as well known, is 60% of the people that go into assisted living do so because they can't manage their meds, okay? And through this system that is simple and can be operated by an 80-year-old easily with no IT skills whatsoever, okay, that individual can age in place longer. I doubt any of us have ever heard somebody say, oh, I can't wait to go into assisted living, right? Nobody has ever said that. And we keep people living independently longer, either through aging in place, long-term care in the home. And that's that's an offshoot of that whole better patient outcome.
So
then the third factor, if I could add, if I could add, it's the peace of mind for the family member, the caregiver. They know that their loved one is taking their meds.
For those just tuning in, we are in the company of Justin Monger, CEO of MedSure Systems, a medication management service that enables better patient outcomes, improved practice operations, and the reduction of total spend. So stay tuned for the rest of the story.
And that's an interesting question. Can this report out to a third-party caregiver?
Oh, yeah, excellent. Sorry, I jumped the gun there on that. Through our app, that a caregiver can have either a paid caregiver or a family member caregiver, they can see exactly what the patient is doing. Has the patient taken their meds or have they not taken their meds? And they can see the report going back 30, 60, 90 days easily.
Now, Gregg and I are sort of no hype guys. So there are always issues with things. And like this one, I'm thinking, my mother, she gets the trays that are all pre-done, and you push the medications out day by day and stuff. The reminders would obviously be a help in those cases, things like that. What do you do when the prescriptions change?
That's a great question. Our partner pharmacy puts out a 30-day supply. So let's say on day 15, suddenly the doctor says, I want you to go from Crestor to Lipitor, or I want you to go from a 10 milligram to a 20 milligram, whatever the change is. We will send along to the patient a vial, a classic vial of the new meds or the new dosage, whatever it may be, for the second half of the month, 15 days of the month. And they'll just place it right next to the machine, and we will remind them, take out the Lipitor that you're not supposed to take and take the Crestor. And then on the first of the month or whenever the refill time is, everything gets synced back up and your new meds are in the strip packs.
And let me ask you this: is that I know with the regular box, if it's just feeding that strip out, I've seen some confusion among various individuals who are suffering from perhaps early stage dementia or things like that, and they'll miss a dose, they'll miss pushing out part of a push pack, or what if they pull two strips out? And does your other automated device only deliver one? There's no way you can pull another?
Yeah, the automated device only pushes out the strip packs that are supposed to be taken at that time of day: the morning dose, the midday dose, the evening dose, or the bedtime dose. If you're not using the device, you can pull out 3 or 4, you can push them back in, but each pack is labeled with the name and the time and what's in it. So as long as you can read on there, it'll tell you. You'll know if it's your 9 p.m. dose and it's noon, you need to wait to take that dose. Does that make sense?
Yeah. And so they'll have this little thing of the new meds potentially beside them. It says, take this sucker out of your pack. And then the next month, you'll send them a new strip that will be the correct one.
That's it exactly, Fred. What we can also do with that is, let's say you've got something that doesn't fit in a strip pack, an injectable, an inhaler. Yep. Then we remind the patient to take the injectable, to take the inhaler.
Mm-hmm.
Okay. And then we ask them, did you take it? So we get the compliance of all the meds they're supposed to take.
Have you thought about some of those products I've seen over the years in which they do almost a directly observed therapy approach with a picture taking the meds versus I took them? Obviously, there's always some little wiggle room in that.
Yeah, absolutely. The studies that we've looked at, or to answer your question directly, yes, we considered that. There's a lot of privacy issues. And then if you make operating this a pain, difficult, or unpleasant in any way, shape, or form for the patient, you're not going to change their behavior. And that's what we found with those systems, because those systems like that have been around for a while, where they want you to either scan the barcode on the pack or take a picture of yourself swallowing the pill. And for the average Medicare age patient,
Sure.
it doesn't work.
That makes a lot of sense. And sort of a sense of how large you are now with this.
Well, right now we're going to be at 100 patients by the end of August. Meaning we've got a whole bunch in the queue. It takes, because of the prescription cycle time, takes about 30 to 45 days from the day the patient says, yes, I want the program, till we get everything set up and get them in and actually start them. So we'll be at patient 100 by the end of August. Right now we've got about a little over 20.
Mm-hmm. And and you talked about this is typically covered by Medicare Advantage plans. Are you seeing any interest from the commercial market yet, or Medicaid?
We know there's some very good candidates in the Medicaid waivered category, but that's a pretty specific. But there's about somewhere between 6 and 9 million people in this country in the Medicaid waivered packet, and we've got some folks we'll be talking to early next year. They want to evaluate one of our devices and see if it can make a go of it, and we believe they will. On the Medicare and Medicare Advantage side, we've got this pretty much covered. We've shown the business model works. So really the two business models, we know the fee for service Medicare Advantage works. The next up is the value-based care, where Medicare isn't paying directly; it's a capitated system. And then the third one would be this Medicaid waivered, where we would have a direct contract with the company that's providing the services to the Medicaid waivered individual.
And could you perhaps give a little bit of a description of what the waiver program is for Medicaid for some of our audience that may not know?
Yeah. In the instance that we're talking about, because it varies a lot state by state, but in these couple of northern states, Michigan, Wisconsin, a Medicaid waiver individual is usually somebody that is developmentally handicapped, physically handicapped, and then on top of that, we'll have 1, 2, maybe 3 chronic diseases. So these are people that are they're really on the edge. Very often can't drive, very often can't work, very often homebound. And the two big issues with Medicaid waivered individuals are, number one, getting them to see a doctor every quarter, because if you don't travel, that's hard to do. And then getting them to stay on their meds. The med adherence rate for these individuals is well below the 50% average. And so these Medicaid waivered organizations are working really hard to tackle those two big problems. Get a telehealth visit once every 3 months and get them on their meds, get them on their regimen, and get them to take them on a regular basis. And we can certainly help with the med regimen side of things.
Great. Thanks for explaining that. And Justin, have you done anything in the app around behavioral economics or gamification or things like that?
Oh, absolutely. We know we've got some pretty fun things on the drawing board, Fred. Me, I'm a dad joke. I love telling dad jokes. I love listening to my daughters just groan. In fact, the longer the groan is, the better that dad joke was. I know that. And we will offer up things like, you hit the button that says you took it, or you hit the button on the app that says you took it, you get the dad joke of the day, or you get a Chinese fortune, or you get a Trivial Pursuit question, or some sort of trivia of something. So there's a number of things we're going through. We have a neurohumorist that's on the team. We have industrial psychologists on the team, and we're looking to bring on some ABA, applied behavioral analytics experts on. And between those three, we think we're going to that's what's going to get us really up to that 99% for the vast majority of people out there, where once again, it's not just a digital intervention. Do you have a technology that beeps? But you've got something behind that. You've got the relational care side, something really appealing to the other side of the coin. Does that make sense?
Yeah, it sure does. And you've obviously, bring together a bunch of data from this, both the data from the app, adherence rates, the individual calls, coaching interventions, et cetera. Does that feed into an electronic medical record or anything now, or can providers access that data?
Absolutely. The bare bones minimum requirement is that we have to have a compliance record that the practice can see, so that when the patient comes in, say for a quarterly visit, they can use our portal, download the data, put it into their EMR system, and it's got all the compliance record for the last 3, 6, 9, 10 months. And that's the compliance record for all the hard pills, all the vitamins, all the nutraceuticals, as well as the injectables and orals and inhalers.
Got it. So you've got obviously these ideas around expanding it out. Where do you take this thing next?
Oh, that's a great question. I believe that I know there's millions of caregivers in this country, or unpaid caregivers, and it's a high stress job taking care of, say, a spouse or a parent or an uncle, particularly as they get older, the cognitive abilities go down, and they don't take their meds on a regular basis. And being able to do that can be a very, very stressful thing, particularly if you've got to go to work every day. And so these caregivers who are doing that right now, it is a small price to pay, direct out of pocket, don't care about Medicare. I just want to know that my dad or my loved one is taking their meds. So we've got a direct to consumer model that the data is available to the doctor if the doctor wants it. Okay, and we don't bother with Medicare billing. It's just something to really simplify the life and the job that the caregiver has in front of them.
And if an individual was to go look at that direct-to-consumer model, what might that cost?
Oh, it's on the order of under $50 a month.
And then the cost of the meds above that are being put into the system, right?
Yeah, the cost of meds, whatever your insurance company allows you to get. Yeah, exactly.
And are there any issues with the two pharmacies you have that perhaps they're not within plan for somebody, or?
Both of our pharmacies deal with 100 plus insurance companies, and 98% of the time, for all the patients that we've even considered, they meet or beat the best prices out there. Every once in a while, like if you've got meds from the VA, they're free. Obviously, can't compete with that. So the VA patients, we're not a good fit for them. But every once in a while, there'll be some oddball brand name drug that they can get a better price but 98% of the time we meet or beat, or our partner pharmacies meet or beat the prices they're currently paying today.
Got it. And as you said, they're in over 100 plus of these plans, et cetera.
Oh yeah. That's all these two pharmacies do. They're not an open door pharmacy. They're no retail. You don't go there to buy milk or bread or beer. It is, shipped out every 30 days to all the patients, and that's all they do.
Mm-hmm. And one other question here. What do you do with the medications that are perhaps just take as needed or something like that?
Oh, great question. Yeah. There's the take as needed category, and then very similar to that, say, is if somebody gets a urinary tract infection, they get a 7-day course of antibiotics in the middle of a 30-day supply of these. So we know about it. Okay. And so for the take as needed, we will ask them, did you take one of your, say it was a painkiller? Did you take a painkiller today? We'll ask them, and they can answer that question, and we'll know. In the case of an antibiotic that they're supposed to take, say, a course for 7 days, we'll say, okay, you need to take day 3 of your 7-day course of antibiotics. Did you take it? And if they respond yes, we record that, and everything goes up to the cloud.
Got it. And so you can add things sort of right in the middle in terms of messaging and things like that.
Yes, through the either through the app, which is obviously on a phone with text messaging and all the rest of that, or through the device itself, which is effectively a phone. We can text and message right to the patient.
Mm-hmm. Do you provide any other education within that, or is it just adherence related information?
Right now, it's adherence related. We do tell the patient they can, through the device, or actually in the next version of the app and through the device, they can hit the details. There's a button we call details, and that will tell them what's in that pill pack that they're about to take, okay, and why they're taking it at the very top level. This is a blood pressure pill. This is for a blood thinner, whatever the case may be.
Fantastic. Well, thanks so much for joining us, Justin. It's been a pleasure talking about MedSure.
Thank you. The pleasure was all mine.
And back to you, Gregg.
And there you have it, folks. That's a wrap on today's broadcast. We want to extend appreciation to our worldwide listeners for tuning in, and our gratitude to Justin Monger, CEO of MedSure Systems, a medication management service that enables better patient outcomes, improved practice operations, and reduces total spend. Do follow Justin's work on the web by www.medsuresystems.com or on LinkedIn. If you find our work at PopHealth Week engaging, please show your support. Give us a thumbs up on your favorite podcast platform. Share it with your colleagues, and do subscribe to ensure you don't miss out on future episodes. Remember, we're live on Healthcare Now Radio weekdays at 5:30 a.m., 1:30 p.m., and 9:30 p.m. Eastern. And for our friends on the West Coast, that's 2:30 a.m., 10:30 a.m., and 6:30 p.m. Pacific. From all of us at PopHealth Week, Gregg Goldstein, and yours truly, Gregg Masters, we urge you to stay safe and stay tuned. And until next time, fare thee well.